Well, welcome everyone. On behalf of the Association of State and Territorial Health Officials, also known as ASTHO, I would like to thank you for participating in today's webinar entitled Cents on the Dollar, Calculating Your Return on Investment, also known as ROI. Today's call is being recorded. My name is Denise Pavletic, and I'm the Director of Public Health Systems Improvement at ASTHO, and I'll be moderating today's session. This webinar is the first in a series of webinars around the topic of accreditation and quality improvement. Okay, today's webinar is brought to you through funding and partnership between ASTHO and the Centers for Disease Control and Prevention, Office of State, Tribal, Local, and Territorial Support. The content of this webinar are those of the authors and do not necessarily represent the official position of or endorsement by the Centers for Disease Control and Prevention. As you already know, the topic of ROI is particularly relevant in today's new normal of budget restraints and cost containment. Now, more than ever, we in public health need to be able to show the value of our programs and services, not only to the legislature, but ultimately to the citizens in the states in which we serve. We are very excited to bring you today's webinar. We have more than 100 people participating today, so we look forward to a robust Q&A session at the end of the presentations. If I can take a moment to orient you to the ReadyTalk platform, there are two ways in which you can submit your questions. The first is through the chat function located on the lower left corner of your screen. You can submit questions at any time throughout the presentation using this function. Your second option is to hold your questions until the end of the presentations, at which time our operators will open up the lines for you to address the presenters. Our objectives for today's webinar are to provide you with a basic understanding of return on investment definitions and approaches, provide you with a basic understanding of how and why return on investment has been used in public health, to explore how return on investment can best be targeted within an agency setting, to provide you with case study examples of determining return on investment, and last, to explore the appropriate use and development of return on investment within agencies. At the conclusion of the webinar, you will be directed to a link to answer a few questions on how well we have met these objectives. In the spirit of our own quality improvement, we very much value your feedback, so please take a few moments to complete the evaluation. I am very pleased and excited to introduce our subject matter experts for today's session. Our first speaker is Karl Ensign. He is the Director of Evaluation here at ASTHO. Karl's expertise includes a unique blend of experience in both the public and private sectors. He has overseen national evaluations as both a federal project officer at the Department of Health and Human Services and as a principal investigator in the private for-profit sector. He served as a senior policy analyst within the Office of the Assistant Secretary for Planning and Evaluation, and then he entered the private sector carrying out numerous evaluations and providing evaluation technical assistance to funded grantees for 16 years. His multi-year projects included the national evaluation of the Court Improvement Program carried out for HHS, the external evaluation of the Kansas Child Welfare System, and the implementation study of the Promoting Safe and Stable Families program among American Indian tribes. At ASTHO, Karl is focused on implementing our organization's Balanced Scorecard, which is designed to measure progress and performance on the organization's strategic map. He also facilitates the development of logic models and evaluation plans, and he provides technical assistance in evaluation, performance management, and strategic planning to our grantees under the National Public Health Improvement Initiative. Our second speaker is Joshua Czarda. Mr. Czarda is the Performance Improvement Manager for the Virginia Department of Health. Prior to joining the Virginia Department of Health, Mr. Czarda served as the Director of Operations for Mid-Atlantic Evercare United Health Group, where he was responsible for providing oversight and development of all operations for Evercare in Maryland, Pennsylvania, Delaware, Washington, D.C., and Virginia. Before joining United Health Group, he worked with the United Network for Organ Sharing, where he served as the Assistant Director for Evaluation and Quality. Mr. Czarda is also principal founder and owner of Raven Chase Adventures, LLC, an innovative company specializing in team building, urban gaming, and fundraising. This company was recognized as one of the most creative companies in Virginia, and they develop and run worldwide events for hundreds of Fortune 500 companies. And then our third speaker is Theresa Green. Theresa recently joined the University of Rochester Medical Center as faculty in the Department of Community and Preventive Medicine and Director of Community Health Policy and Education at the university's Center for Community Health. Ms. Green is responsible for initiating, assessing, and monitoring policy changes that affect the health of the community, as well as assuring community engagement in education at the University of Rochester Medical Center. Before coming to Rochester, Ms. Green was the Director of Community Health Planning from the Berrien County Health Department in Michigan and worked on several issues critical to public health there. Theresa comes from a clinical background as a certified anesthesiologist assistant with over 15 years experience as an allied health care provider and 15 years in promoting allied health awareness nationwide. Theresa is currently a PhD student. She's currently a student in the PhD program for interdisciplinary health sciences at Western Michigan University, and she is working on her dissertation linking social determinants to health outcomes using the county health rankings. So without further dialogue, I will turn it over to Karl Ensign. Karl, go ahead.
Okay, thank you very much, Denise, and thank you everyone for joining us today.
And if everyone would just bear with us while we switch over to Karl's computer.
I believe this is working. Sorry, this is new technology. So ROI is not all serious subject. Actually, if you Google ROI, you will find some jokes associated with it. I thought I would start with that since we will be spending our day today on some rather weighty subjects. Is everyone seeing the screen I'm seeing? Maybe not.
No, Karl, we're not seeing your screen.
Okay.
Did you share applications?
I did.
And then PowerPoint?
PowerPoint? Okay.
There we go. I think we've switched over now, Karl.
Sorry about that, folks. Okay. If you lend someone $20 and never see that person again, it was probably worth it. Money is not the most important thing in the world. Love is. Fortunately, I love money. I always borrow money from a pessimist. He doesn't expect to be paid back. I like that one. And the last one I found is a very good quote from Benjamin Franklin, interestingly enough, which frames, I think, does a very good framing of ROI. An investment in knowledge pays the best interest. Because really what we're going to be talking about today is the use of ROI as a tool, an evaluative tool, to enhance knowledge development and inform decision-making in a particular way. So the big picture before we get into specifics. We are all very familiar, and Denise talked about this some herself, about the fact that we are in an era where continuous improvement and the documentation of outcomes is a constant worry and concern and challenge for all of us. On the national level, we have certain mandates codified in the Government Performance and Results Act and certainly in the Affordable Care Act to undertake efforts in this area. We also have various programs that provide funding and assistance for undertaking continuous improvement and documenting outcomes. For instance, the Multi-State Learning Collaborative, and I believe most everyone here is participating at some level in the National Public Health Improvement Initiative. Accreditation, of course, we are all very familiar with that. So those are some of the mandates of investments that we have available to us. And we also, of course, have the constant tug and pull of several opportunities and challenges, including budget battles, information technology and communications advances. We have more and better information available to us to assess performance, and sometimes that can become a little bit overwhelming. And of course, we have the increased need for public health. Also as context, of course, we have the 10 essential health services, which stresses evaluation, and FAB, specifically Domain 9, of which we are all very familiar with, to evaluate and continuously improve processes, programs, and interventions. So I lay this out as context because I think this underlies much of what we do on a daily basis in terms of thinking about public health here at ASTHO, and I'm sure these concerns are on your mind as well. And then I want to place ROI within this context, specifically define ROI. And as Denise laid out, our first objective for this webinar is to provide a basic understanding of ROI and define it. So within this context, we define ROI as a form of analysis. And by that we mean, if we're thinking about evaluation, evaluation hinges on the comparison or documenting some change or looking at an outcome over time. So we might compare changes in knowledge, status, behavior, function, values, and we see a positive or a negative change or no change at all, and we learn something about what we are doing within that context. Similarly, ROI, we compare the cost of an intervention with its benefits in financial terms. So we're looking at an outcome, but in a different way. We're looking at the costs associated with it, we're looking at the benefits associated with it, and we're looking at changes over time and how these play out in financial terms. It follows a business model. The goal is a positive return and figuring out where exactly our benefits are maximized in relation to our costs. So how do we calculate ROI? There are several terms here. We have cost-benefit analysis. We have return on investment. The definitions, quite frankly, are a little fuzzy and not always well-defined, but basically if we think about a net benefit, that simply is derived by taking the sum total of all benefits associated with an intervention or program and subtracting from that the costs of undertaking that. That would yield the net benefit. With ROI, we take the benefits and we subtract the costs, yielding the net benefit. And we place that over the costs associated with it, so we come up with a proportion. So ROI in its purest sense is a proportion of benefits in relation to costs. So here I have some hypothetical values laid out. But if we had a particular undertaking or program or intervention that cost a total of $1,200, $400 plus $500 plus $300 in benefits, we subtracted that from that a sum total of $200 in costs. We norm that over costs, we'd come up with the ROI of $5. Or, stated indifferently, a dollar spent on pediatric immunizations is estimated to save $5 in treating preventable illness. And this actually comes from a study which was carried out on this very subject. So that's the function of ROI, is looking at that proportion of costs in relation to benefits and finding out where exactly benefits are maximized, or the return on investment. So that's our overview of our first objective. The second objective is to provide a basic understanding of how and why ROI is used in public health. And we've already gotten into some of the why, simply with the pressures for increasing efficiency and documenting outcomes, and if we can do that in dollar terms even better, is some of the why that underlies undertaking ROI. But how exactly has ROI been used? We have looked at that here at ASTHO, and we found that most fundamentally and traditionally, ROI is used to look at the return on investments for specific program areas. And we'll provide some examples of those as we go along. Secondly, and more recently, it's been used to look at aggregate public health spending in terms of costs and the benefits that can accrue from that spending. That's a fairly new and emerging area. The area most in infancy that we find at this point is determining ROI for QI projects undertaken by agencies or quality improvement projects. And that is really what we're going to focus on today because we feel it could be the most germane to those on the phone, as well as it provides some interesting benefits along with challenges. First of all, the program examples of ROI. We probably are familiar with these in the injury prevention area. The Pacific Institute Research and Evaluation has put out a study on injury prevention, finding a $14 child bicycle helmet can prevent $580 in medical expenditures on average. Similar with the Call to a Poison Control Center, we have costs and benefits. Our Robert Wood Johnson Foundation has pulled together in its issue briefs a number of different program examples of ROI, tobacco prevention and control being one of them. Other examples of ROI for program areas have been conducted on HIV prevention, unintended pregnancy, community water fluoridation, so it really covers the gamut. And as you can see, this area of ROI in public health, there's plenty of work to be done, but it's probably the best developed area, if you will. We also talked about the second area in which ROI has been conducted in public health is on aggregate public health spending, a relatively new area. But some work has been done on this. There's a couple of good articles in Health Affairs published in July 2011 and May 2011 that looked at a decade of public health spending and mortality rates and looked at the benefits in terms of mortality. It was estimated that for each 10% increase in spending, there were significant decrease in infant deaths from cardiovascular disease, et cetera, et cetera. And that could be monetized into a return on investment, a positive one. Similarly, another study found that the cost for combating cardiovascular disease in a clinical setting was over 27 times higher than doing that through preventative public health measures. Again, validating in monetary terms what we do. A related study analyzed the impact of 3 strategies implemented both separately and together: expanding health insurance coverage, delivering better preventive and chronic care, emphasizing protection strategies, and the benefits that accrued from undertaking these. Again, I provide these just as examples of ROI in program or functional areas of public health as has been done traditionally and most extensively, and some work in monetizing the benefits that accrue from our public health spending. This also is found to have been done on a community level as well. Trust for America's Health looked at community-based, multi-component community-based disease prevention programs and looked at the return on investment for those programs in a February 2009 report. Today, again, we're going to be spending really the remainder of our time looking at looking at ROI, on QI projects undertaken. And certainly Josh Czarda and Theresa Green will tell you how they carried those out directly overseeing those efforts. I wanted to provide a little background before we turn it over to them. So when you look at all this together, I think we can see that ROI is well suited for our times. It provides a compelling case for the investments we make. And it's one way of measuring and communicating public health effectiveness in a manner that we believe can be particularly salient for policymakers, funders, administrators, and the general public, telling the story about what we do, telling the benefits of what we do, and telling it in a very tangible way in terms of dollars spent and dollars realized. There are challenges, though, that we shouldn't shrink from either. A dollar spent on immunizations yields $5 in avoiding preventable illness, or $10 per person investment in comprehensive community-based programs saves $16 billion in 5 years. Really, it leaves us with the question, do such statements really help public health agency functions in their yearly pressure to kind of validate what they do, justify their budgets, find where their budgets, where their expenditures are most efficacious, and on that level. So certainly challenges from an agency perspective emerge in terms of conducting ROI, and we don't want to shrink from those. For instance, an investment may take years to produce benefits, and we may not have years to measure the benefit in monetary terms of what we undertake. Benefits may be difficult to link back to a specific public health function. There may be other intervening factors in a community setting, in a population setting, that really allow us to say that this investment led to X dollars in terms of benefit. Very important, benefits may accrue outside the agency. So it's certainly within our mission to avoid preventable illness, to avoid injury to the general population, but those are not things that can directly accrue to our agency budget. They're a little removed. And of course, with all efforts such as this, new data, we need to acknowledge the fact that new data may need to be collected to undertake this correctly. So we like to think of this as going forward, and the issues we're going to look at and the approaches we're going to look at is perhaps providing a bridge to overcome some of these challenges. So partly that resides in looking at ROI from a quality improvement perspective. There are certainly disadvantages associated with that, in that the ROI tends to be narrower in scope. It is more modest. It's in terms of agency efficiencies realized. Putting those in dollar terms are more modest, perhaps, than some of the other things we've talked about, some of the other concepts. But on the positive side, they're more immediate, the time frame is shorter, and they accrue more directly to the agency. The pathways to realizing ROI for QI, and here we're getting into our third objective, exploring how ROI can best be targeted within an agency setting. And I give full credit here to Glen at the University of Kentucky, who we've been working a lot with on this very subject. In terms of realizing a positive ROI for QI, we can think about reductions in standard operating costs, greater efficiencies realized through paperwork automation, data sharing. We can look at revenue enhancements, increasing cost reimbursement through fees recouped, Medicaid reimbursement. We're going to hear some more about that later in our case studies. Increased productivity of agency functions, so thinking about increasing service encounters, better targeting or disbursement of immunizations, inspections. Decreasing the time to produce the outputs that we undertake, reducing cycle time process. For instance, thinking about field data entry when we're doing a restaurant inspection and the efficiencies that can be realized with that. So these are some of the ways in which ROI can be best targeted within an agency setting related to QI. So it occurred to us that we need a practical tool about a little over a year ago to help agencies calculate ROI. And one of the things we're announcing now is that currently undergoing beta testing is a very exciting effort through funding from the Prevention and Public Health Fund, ACA. ASTHO pulled together a work group along with our partners from CDC, our funders from CDC, state and local health agencies. Josh and Theresa are involved in this work group, foundations, academia. We developed a tool for health agencies to measure ROI for QI initiative projects, such as those being undertaken through the National Public Health Improvement Initiative, or NIFI, through which this tool was funded. And this is probably an overstatement. I think there are tools out there, but this tool leads to, is really groundbreaking in its approach, we feel. And again, we we pulled on the expertise of Glen, University of Kentucky, to help us with this effort. So currently this tool is being beta tested by several members of the work group, including some of those you'll hear from later from this, in this presentation. So the tool basically is a template which prompts users to think through and enter data to come at those pathways to realize positive ROI we talked about, to think of net benefits in relation to costs. It prompts users to think about personnel and non-personnel costs incurred in the planning and development stage in relation to the ongoing operation. The routine operating costs of the unit where the strategy is implemented, again, before and after implementation. So it does these key comparisons over time and over a number of different cost categories that help derive the ROI on efforts undertaken in terms of units of service delivered, production time required to deliver services, reach, et cetera, et cetera. So I'm going to close out here with just a few lessons learned through the effort we have undertaken, and then turn it over to Josh and Theresa to talk about the specific approaches they undertook. I want to close on the appropriate use and development of ROI within agencies. So again, I want to emphasize that ROI is one tool of several to be used for decision-making purposes. It can very much help inform funders and administrators' fiscal decisions in several ways. That is, determining the point at which ROI is maximized for a program, weighing the relative value of alternative programs or activities when investment dollars are limited, as they are today. But hasten to add that ROI is not always appropriate or feasible. There may be other questions on the table that need to be answered through other evaluative mechanisms, and quite frankly, the data needed to estimate ROI may not be readily available. ROI is not the be-all and end-all, though it is a powerful tool. If we are undertaking ROI, we wish to emphasize that it's important to build evaluation methods, including ROI, into program inception whenever possible. It is important to view continuous improvement through evaluation or ongoing assessment as part of the new way or part of the ongoing business we undertake. It helps minimize perception that data collection, analysis, and reporting are additional and burdensome if we do this. And building evaluation in from the beginning can also help ensure the collection of baseline data prior to full program implementation, a key concern whenever we are undertaking evaluation. The work group really keyed us into the fact that it is very important to clearly specify the intended purpose and use of ROI. Quite frankly, the data needed to conduct ROI can be sensitive. We're talking about staff time and salary, et cetera, and the valuation of program impact can raise concern among those responsible for collecting and tracking needed data. Therefore, really an educative process is needed both internally with agency staff on the purpose and use of ROI, and really externally as well with policymakers and funders who will be running with the information that is derived through this technique. And this helps minimize staff resistance and helps ensure that results are not misused from their original purpose. It's important to conduct ROI through a transparent process. It's important to demystify the process of determining ROI, spoken another way. Otherwise, the analysis may be looked upon with suspicion and the results may be questioned. Transparency helps this. And finally, we want to conduct ROI through an inclusive process. Just as we did with the development of the tool, ROI tool that we talked about, it is advisable to form a work group representing a cross-section of all relevant parties when undertaking an ROI analysis. Include those who will supply data needed for the analysis, staff involved with the operation of the program, or activities which are the focus of ROI. Include those most familiar with needed data, such as financial officers and others. Include planners and administrators, and also think about including end users of the analysis. Again, the funders and policymakers. This can also help with transparency and buy-in. So that concludes this section, and I am now going to turn it back over to Denise to introduce our other speakers.
Great. Thank you so much, Karl, for providing us with that background. I will be now turning over the presentation to Joshua. And Joshua, give me 1 minute to pull up your slide.
All right.
All right, great. So I've pulled up your slide, and you should be able to advance your slides. If not, let me know. Go ahead, Josh.
Give it a shot. All right. Is that advancing okay? All right. So I'm with the Virginia Department of Health. Just as kind of a reminder and overview, we are a centralized system. We've got about 3,800 employees. We have an annual budget of $620 million, and we serve a population of about 8 million folks. Overall, we comprise 35 different health districts. We have 119 different health departments, and our performance improvement unit, which was started under the NIFI funds and in existence for about almost 2 years now, reports directly to the commissioner here, which has helped greatly. And so when we set out on our efforts, we really wanted to hone in on projects that yielded some type of ROI. So for the next about 9 minutes here, I'm just going to walk through 3 of those projects that we went through and how we went about calculating some of the return on investment for the projects we undertook, as well as some of the challenges that we faced in terms of calculating the ultimate return on investment. For us, in terms of tracking and the tools that we utilized, we have an Excel dashboard system that we've developed. And for any of our performance improvement projects, one aspect that we've done is to really focus in on the baseline data, ultimately track whatever performance improvement initiatives we undertake. So the changes in the processes, the changes in the time and the money and that type of thing, and ultimately the health outcome to help us ultimately determine the ROI for that project. Similar to what I guess Karl was saying, to get to ROI, you need to take the benefits minus cost over the cost. But to get to that level before you go down that path, you need to figure out what really the benefits of that performance improvement project are. So for every project that we've undertaken, we really start with baseline data, and we try to get the current unit costs as well as any current process costs to give us a total baseline. And from that, once we either map out the performance project we want to undertake or measure the one that's already been implemented, we really look to see what are the revised costs, what's the revised process cost, ultimately how much we spent on the project overall to give us kind of that overall new cost, which from that we can get our benefit from, and couple that with the project cost, we can ultimately determine what ROI is. Now, there's all types of challenges with that, especially when project costs aren't fixed and that type of thing, but we'll get into that here shortly. One very, not simplistic example, but this is one of my favorite examples from the Virginia Department of Health. This is a process that's been in place as long as some of the employees that have been here. Very hard to read. It should give you a headache just looking at it. But this is our HR 14 process. So when someone leaves the Virginia Department of Health, they have to get checked out of all these different systems, all these different computer systems, turn in their badges, turn in their keys, all that good stuff, and kindly escorted out the building. As it stands, this involves over 20 different people. It takes anywhere in excess of 30 days to complete. And it's costing the agency about $139,000 in time and effort. So this is a process we focused in on. We wanted to see if we could really make it better, and it wasn't really hard to improve upon it. Basically, we boiled it down to a 1 to 2 day process that should only involve about 3 people altogether, and reduce it from 20 steps to about 12 steps, ultimately yielding us about $70,000 in time and effort savings a year. So this was a real straightforward project. Basically went through it in a day or two, all the project costs right there out front, and then transitioning it over to our help desk, which is basically our computer folks here, to take over the process was really a one-time shot. And so annually, every year going forward, we should see this type of savings in time and effort. Now, time and effort is only as good as time and effort. So moving on, we started some real-world dollar projects. For us, second project here is our IT savings. So we have, as I said, 3,800 employees. We have a very, very expensive IT system that is a contract through the state. Basically, it costs us $18.5 million a year to service those 3,800 employees, and this has been going up exponentially over the last couple of years. So we took a look at it, and we found a couple of different areas where we could maximize our savings. One was in the method how we store our data. We got charged at different rates. One was for the cloud data services, which everybody's kind of familiar with nowadays. And the other one is from those giant disks from like 1970s where we stored all our data on, and we got charged at a much, much higher rate for that. So we wanted to see if there's a way we could switch over all our data. Another large area was just in overall inventory. We had more computers and laptops and all that good stuff than we did employees, and we got charged a monthly fee for all of that stuff. So we wanted to see, how can we reduce those costs overall. So this has been a more complex project, and as we've gone through it, we have realized some fairly significant annual savings. In terms of how we store our data, we have the potential to save roughly almost $677,000 a year by transferring our data to a more modern system, and we had a chance to save about $214,000 on reducing our overall inventory of computers. From that, we've initiated a number of processes where our IT folks have gone in there, and we've worked with various departments to switch over our data and reduce our inventory, but as are many things in public health, it's been a very long and tedious process. So our project costs have been carried over from year to year. So far, we have realized about $500,000 in annual savings that we'll save every year going forward. But our project costs have remained fairly low. We've got about a 12-to-1 ratio in return on this, but it's something that's more challenging because in working with all these departments and calculating everybody's time to actually work through the processes necessary, it's been a tougher road to nail down exactly what our return on investment is, but we've still been able to come back and say, hey, look, we're at least saving you $500,000 every year going forward, and that'll go into perpetuity. More complicated still, one of the projects that actually impacts public health here is we worked on increasing enrollment in Plan First. And Plan First is a Medicaid family planning program. It has classically had very, very low enrollment. It has been a process, as you can see on this screen, with all the Batman, Shazam marks, or whatever you want to call those, all types of barriers to it, from knowledge of the system to how we enroll it to how we work with our Department of Social Services, Medicaid, and all those good folks. Lots and lots of different barriers. So we've had collaborative groups. We've been revising the process, putting out communication efforts, working with our local health districts, and we've had great success here. We've gone from about 6,000 employees, 6,000 enrollees, which is cut off the screen, to roughly about 32,000 as of the end of October. From this, we have had fairly significant return on investment in the sense that we've seen over $1 million in additional new revenue coming in for billing these services that we normally might not have billed for or would have been reimbursed through another channel. So it's been a very large increase in revenue from that aspect from it, so very successful in that sense. However, the hard part really comes from measuring the long-term impact of what that investment will be. So putting these folks on Plan First, giving them birth control, avoiding unwanted pregnancies, decreasing abortions, that type of thing. We have great trouble actually calculating the difference in the incident rate between the folks that we actually service through the program through the folks we may not be reaching. We have trouble assigning causality to say, because they were in our program, we actually lower the incident rate to X, and therefore we have saved X amount of dollars, and that type of thing. So that's really the kind of the holy grail of ROI that we have been working with ASTHO on, and we want to push forward as we go on. I've got about 1 minute left here. So just some of the challenges. In terms of ROI, the tools I think must be fairly flexible. We've been working with ASTHO on their template to really get something down that we can manipulate across the board and to try to keep it simple as simple as possible. For us, illustrating ROI, even in the straight-up dollar figures, has been critically important to prove that our PI program is indeed valuable and that we are making a difference, because that's a great challenge to show in something like accreditation. But if you can come back and also say, hey, and in doing this process, we're saving you $1 million plus a year, you're in much better shape. And then ultimately, the takeaway is I think that holy grail is if we can start to really calculate and agree upon how we calculate ROI for long-term impacts to health outcomes, we'll be in much, much better shape across the board. So that's it for me.
Thank you so much, Josh. We appreciate you sharing your experience there in Virginia. And so let us turn it over now to Theresa, and Theresa will be discussing her experiences while she was with the Berrien County Health Department in the state of Michigan. So go ahead, Theresa.
Thank you. Hopefully you can see my first slide. And as you can see, I'm in Rochester right now, but the information that I'm presenting is from Berrien County, Berrien County Health Department, where I was the Director of Community Health Planning. Berrien County is located in Michigan, and so we are no stranger to accreditation. Michigan has a long history of state accreditation that we've been a part of since the beginning. Our Berrien County Health Department has about 90 employees, 3 general service areas, and a county population of about 140,000 with a much smaller budget of $8 million. We have been, as I said, doing accreditation for a long time, and we have linked accreditation, efficiency, and quality for years. So when Robert Wood Johnson came out with a grant opportunity to measure efficiency in quality improvement, we jumped on it. We really closely see the tie between accreditation and quality improvement. So our baseline is set by accreditation standards, and our areas for improvement are identified during accreditation process. When we identify areas for improvement, we begin our rapid cycle improvement iterations based on a strategy for each intervention, hopefully leading to improved efficiency and improved quality without diminishing either one. And then over time leading to improved measures during accreditation. So that's where we focus, and trying to move from little intervention-wide CQI to big department-wide CQI. So we did have a Robert Wood Johnson funding opportunity to measure efficiency in quality improvement projects, and we focused in 2 strategic areas within our health department, the first being the Children's Special Health Care Services area. This program was really struggling, and the biggest problem was they weren't able to bring in enough revenue to the point where the state was fairly concerned about shutting the program down or figuring out some pretty drastic changes in order to improve our revenue. In addition, the manager was getting complaints fairly regularly from clients that folks were not getting their issues resolved in a timely fashion. So through the CQI process, we developed an aim statement to increase the number of billable client encounters by 20% while improving the level of current customer satisfaction. And we had about 1.5 years in which to implement the changes. Again, we talk about measuring. We had to figure out ways to measure that improvement. So customer satisfaction surveys were done, response times needed to be measured, and then billable and non-billable client encounters had to be calculated in order to show an improvement in revenue. We did several PDSA key quality improvements that were developed through the folks that were on the ground doing the work. And a big part was starting a tracking system in order to analyze the data, because you cannot measure return on investment without quantifying some form of data. So we had to measure what was improving and then quantify that unit in order to calculate efficiency. Yeah, we were asking why the frontline staff was not able to see more clients to generate more billing, and they were telling us they were inundated with doing tasks that had nothing to do with clients. So a lot of our process here was redelegating tasks to the most appropriate folks to do the work so that our frontline people could actually see patients. And in the tracking process, we measured response time because that was the primary problem. So this is just a picture of the results data as we looked at time to respond. So the blue spaces are time to return a call when a client called in, and the red bars are the time it took to actually get the job done when a person had a complaint. These decreased over time of our intervention, and the yellow indicates different ROI, or excuse me, not ROI, rapid cycle improvement changes that we made along the way. So along with that, we did see a definite trend in increasing billable and non-billable time. In the beginning, we were not even tracking non-billable hours, hours that our frontline staff spent with clients that we didn't think we could bill right off the bat. We found out through the process that we could batch those hours and bill them over time. So by developing a tracking system, we were now able to quantify those non-billable hours and then bill for them. So over time, with each CQI, or with each CQI rapid cycle improvement, we were able to see increase in billable and non-billable hours over the year that we did the intervention. And we had set a goal to have a 20% increase in revenue. We met that goal in the first quarter of doing the intervention, so CQI definitely worked in this case. By the end of the year, we had a 76% increase in revenue. But in addition to that, we had qualitative positives that led to improved financial situations as well. So all the reporting was much quicker. It was already recorded, so it was kind of a touch of the button results if you needed a report. Monthly meeting time changed around, and by that reallocation of jobs to the people that needed to do them, we saved staff time as well. So in revenue alone, we saved $15,694 just in seeing more clients. By shifting the clerical and the billing duties from the nurse that was doing administration and billing to an administrative assistant, she was estimating doing about 5 hours a week on just billing and clerical work, times 52 weeks times the $14 difference in salary yielded a $3,647 change in salary. Again, small changes, but compared to the size of this program, very significant. And then in the reporting and auditing, this was a funny story. I came into the office and the manager of the program was all excited because she had been called for an audit. The state was shocked that our revenue had gone up so significantly, so started an audit to see what had happened. And in doing so, the audit process would have normally taken her days, she said, to accomplish the task. But in 3 hours, she was able to give the state auditing folks what they needed. So that difference in staff time of a supervisor from 3 days to 3 hours was another $500 per incident improvement. So $20,000 just in this alone. During the same Robert Wood Johnson grant project, we also looked at environmental health with the food service, and the difficulty here was getting re-inspections of critical restaurants, getting the inspectors back to do re-inspections in a timely manner so that restaurants were not sitting with critical violations. The aim statement was to decrease the occurrence of fixed restaurants with critical violation in any month by 20% without increasing staff time or expense. And again, we had to pick something to measure and then start measuring it. So we measured the time that a restaurant stayed in critical violation. We also measured the number of restaurants with criticals, but really focused on the time it took to get back to those with critical violations. We did several quality improvements here, and they are similar to the ones that we did with the with the Children's Special Health Care Services in tracking and reallocating tasks. And we found that over time, the number of days it took to get to reinspection when we started was about 18 days on average. The accreditation standard is 30 days, and our guys wanted to be under 14 days. And by the end, we were averaging around 10 days to get back for critical reinspection. We also mapped our quality improvement interventions along this timeline and hit a critical about halfway through the process. We measured it a different way, showing the percent of criticals not reinspected before the 14 days, and that went down significantly from half of them not being reinspected within 14 days to down to under 10% by the time we were done with the intervention. And this too resulted in both quantitative and qualitative ROI or increased efficiencies in the project. One of the major things that we saw by looking at the data was those that were often thought of as being slow actually were doing twice as much work as some of the others, and were doing much worse case scenario restaurants, so a lot more work on their plate. The computer was an interesting thing. All the inspectors had computers with them so they could do on-site inspections with their computer in hand, but instead they were often keeping their computer back at the office, driving to the restaurant, doing the inspection, driving back, entering the report in the computer, then driving the report back to the restaurant for signatures, and then driving back to the health department to turn that in. And so during the process of CQI, showing the guys the data, the inspectors the data, they started thinking about ways in which they could improve their efficiency on their own. And one of them, at least 2 by the end of the process of the 5, had started using their computers on site. So using the computers on site yielded a cost differential for sure. So the hour and a half time it took even just to drive back and forth between a restaurant over the 200 inspections a year that one inspector does, times their $24 an hour rate of pay, yielded $7,000 per inspector. So we had 5 inspectors. If all 5 were on board, that was quite significant. In addition, the travel time back and forth from the restaurants, another $1,500. The manager spent time tracking late inspections every week, at least an hour at a supervisor managerial level. That's an additional savings of $1,600. And then, of course, the ultimate cost would be the resources saved for averting a foodborne outbreak, and that, you know, is the holy grail, as was stated. What does that cost? And that is definitely difficult to quantify. Moving to big CQI, we have developed interventions for CQI at each of our 14 objective areas throughout the health department. So if each of them has the success that the smaller one-year interventions had, you know, multiply that 10 to 20% increased efficiency over the 14 key objectives, and you start talking about real savings to the health department. So I like to keep things simple, and we did it on a small scale, but that's how we measured return on investment for our health department.
Great. Thank you so much, Theresa.
Sure.
And so at this time, Nikki, if you could open up the lines for us to receive questions.
Thank you. Ladies and gentlemen, if you'd like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you'd like to withdraw your registration, please press the 1 followed by the 3. You may also ask a question using the chat feature located in the lower left corner of your screen. Once again, if you'd like to queue for a question, you may press the 1, 4 on your telephone. One moment, please, for the first question.
Thank you, Nikki. And in the meantime, while we're waiting for that first question, I did have a couple of questions come through the chat function. Several of you have asked if the slides will be available, and the answer to that question is yes. This webinar is being recorded, and so I will follow up with all of you to provide you with the link to the webinar as well as a link to the PowerPoint presentation. Nikki, are we ready for our first question?
There appears to be no questions from the phone lines at this time. However, as a reminder, you may press the 1 on your telephone.
Okay, so then we can move on to another chat question. This was probably more for Karl. Karl, you talked about the ROI tool and that it's currently being beta tested at this time. What is the timeline for release of the tool?
Right, I did see that question, and some of those, it's a little bit of an unknown because this needs to go through some clearance processes associated with ACA funding at CDC. I would hope that we can have that template ready to go, beta tested and cleared by the spring. But certainly what I would like folks to do is if you are interested in it, contact us now, and so that we can make sure that you get it as soon as it is available and continue to communicate these principles to you and one thing and another. So if you are interested in it, please drop us a line, and I will start a discussion with you on how we can get it to you as soon as it is available. So no easy answers, but we are certainly shooting for the spring, if not before.
Great, Karl. And I will be providing my email address at the end of the presentation. So folks who are interested can certainly shoot me an email.
And pardon me, we do have a few questions from the phone lines at this time.
Great, go ahead.
Perfect. Our first question comes from the line of Mike Messinger. Please go ahead.
Hi, I'm from Texas, and a couple of just simple questions. Will we get the slides that were presented today?
Yes, the slides will be available. I will send out a follow-up email to all those who have participated today with the link to both the recording as well as the slide presentation.
Thank you. And then my last question is, I'm kind of new to ROI, so I'd like to find out if there is a listserv or maybe a group nationwide that talks about their experience with doing ROIs, and that we can share and ask questions on.
This is Karl. I think that's a fantastic idea. I personally am not aware of any listservs or groups dedicated to that sole function. Maybe Josh or Theresa could, or some other participants could correct me if I'm wrong. I think that's a terrific idea, and I appreciate the suggestion. So let's think about what we can do with that.
Wonderful. Thank you.
And our next question comes from the line of Melinda Simmons. Please go ahead.
Yes, hi. I just had a question about time savings. If, as one of the examples that we had where there were so many hours that was saved and it was calculated into a monetary cost savings, is that a true cost savings if you don't get rid of that employee and that employee is then doing other things because we're really not truly, do you see what I mean?
Cutting budget.
Yeah, we're not cutting budget. We're not spending any less money. We're just saving time where that time can be reallocated elsewhere.
Yeah, this is Josh. I think that's a good question, and that could it can go both ways. So, you can undertake a project where you reduce the overall time, but until you actually, maybe if you get rid of that employee because you've automated it, then you can really count it. And the example I put forward, we put it forth as time and effort saved specifically for that one. And
yeah,
I think
I saw on one where.
Yeah,
I saw on one where it was the days was basically the return on investment, it's been kind of an ongoing debate over here.
Yeah.
And my other question. Go ahead.
Oh, I would never undervalue it. I think if you can quantify it and say, look, we freed up 50 hours for staff to do.
Right, and that's usually what we do is time savings. to do other activities. And I had one other question, is that I didn't really see any examples, in the healthcare, like we license, we're in the state of Florida Department of Health, in the Division of Medical Quality Assurance, and we license individuals. Well, a lot of our projects that cost money and all, there really is not a return on investment other than efficiencies for processes. There could be some time savings, but primarily it's for the licensees. So it's really more efficiencies the project is costing that's going to benefit the licensee, but yet there's no way to actually turn it into a monetary return. Yeah. So how do you know how we would calculate, come up with that? Did I make sense?
Not quite sure of the question, but I mean, this is not easy work. This is the bottom line. With all evaluations and all outcomes, we're frequently faced with the dilemma of how you really measure change. So you'd have to think, as Josh and Theresa kind of walked through, what are the benefits that accrue from undertaking a certain activity, and then how would we measure that? What are our expected goals in terms of what is realized by the licensees in terms of their benefits, and then can we turn that into a monetary benefit? It's not always something that's doable.
Yeah.
And then finally, that benefit may accrue outside the agency. So it may be something that is a great benefit to the licensee. It may be something that can be monetized. It may, in fact, be external to the agency. You had a role in playing to help them realize that, but it's not something that comes back to directly benefit you. So these are all things that need to be thought through from the beginning in order to properly target ROI. The other thing is, and I see there's some discussion here in the chat box about equating cost savings and budget cutting and that sort of thing. I guess ROI could be used for that, but again, ROI is really about a return on investment. Did we realize a return or did we not? At what point is that return maximized? How can we do the most with the dollars we have? How can we reinvest them? How can we make sure we're investing dollars in the right way? If we have multiple options to invest dollars, where should we invest them? Those are the sorts of questions that ROI is particularly well suited to answer. I suppose cost cutting and budget cutting could be in the mix, but it isn't one that necessarily comes to mind in terms of realizing the benefit from undertaking one approach or multiple approaches that are on the table.
Okay.
Great.
And I'm showing no further questions from the phone lines at this time. Ms. Pavletic, I'll go ahead and turn the call back to you.
Great. Thank you, Nikki. So we do have some questions coming through the chat, through our chat function. One of those is related to both the Virginia and the Michigan examples were service related. And the question is, does the beta version of the return on investment measure public health non-service? Example would be education or policy efforts.
Josh, Theresa, I'm leaving that to you.
Yeah, I don't have the tool, so I don't know if that's effective for other things besides service. I think the measuring CQI could be effective for any kind of program, but certainly to measure the benefits of education, you definitely need to stretch that out a little bit longer. It's not quite as an immediate result.
Yeah, and if the question is, will the tool help measure that? Only so much as you can quantify the impact of that policy or that prevention program, which was a bit of the point on the that Plan First program. So where we can easily realize that we've garnered an extra $1 million in income, it's much, much harder for us to say, because we implemented this program, let's say 1,000 less women became pregnant, and from that we were able to save X amount of dollars for the state. So I think that's the place we all want to get to. And there are thousands of studies out there on various components, but it's not easily quantified anywhere, and you have issues with causality, incident rate, and everything else. So.
Yeah, in my opinion, I think there's a great role to be played for the logic model to really, before you start the process, show what change you expect along the continuum there, and then measure your return on investment at each step.
Right, I agree. Again, taking an evaluation perspective, looking at outcomes you want to achieve, thinking about how you would measure those, and then whether or not it would be good and appropriate and feasible to do that in a monetary sense.
Yep.
I'm not quite sure about the question, but I do point to the fact this often comes up. What about the unquantifiable? Goes by different names. I like the fact that Theresa included in her slides, qualitative evaluation findings. So you can have an evaluation that contains ROI, or you can primarily go after ROI measures and outcomes. That doesn't mean you shouldn't, along the way, document other intangibles that accrue as a result of the work you're undertaking, and document those as well in a quantifiable term or a qualitative term, for that matter.
Great, thank you guys. I do have another question that has come along through the chat function, and this one is for Theresa. Theresa, have you noticed, or do you know if there's been a decline in improvement over time, and what is needed to sustain the improvements that were made in Michigan?
Yeah, that's a great question. Thank you, Julie. Yeah, I am no longer at the health department, but I will say for a year after the Children's Special Health Care intervention, we still tracked the time to get back and the revenue, and both of those were continuing to improve, albeit at a slower rate. So we did do spot checks every couple of months for about a year after that. I think the sustainable piece that was important for us is one person dedicated to the CQI. So the groups would meet to talk about regular business of their groups regardless, but somebody needed to come in to remind them of the CQI and to present the data so that they were constantly aware of what was happening, what the trends were, and what we could do to improve. So when that piece was taken away, we definitely had a lag. I would highly recommend in an organization to have one person in charge of CQI, and it doesn't have to be a all-encompassing or full-time spot at that, because I don't think anyone has the money for that, but somebody to kind of keep that in their mind to improve the sustainability.
Thank you, Theresa. I'll just go back to Nikki. Nikki, are there any questions on the phone lines?
And at this time, we do have one question queued up. It won't be long until we announce the next question.
Okay, so while we're waiting for that one to come up, I have a question for all three presenters. In practice, how do you distinguish savings associated with a QI process and the return on investment of prevention practices?
Well, in the best case scenario, you do a prevention study without a CQI intervention, and then you do one with a CQI intervention and measure the difference. But I don't know that all of us have the time to do that. I think it's a fair assumption to say things would continue as planned without a definitive QI intervention. And if you're setting out to do that, you can definitely measure the effect of your work. Josh?
Yeah, I'm not sure my answer would vary much from yours, so I'll leave it at that.
The only thing I'd add is before we're getting close to the time here, and I want to make sure we have time to just cover this. I think there is a lot of these are things that it's hard for us to answer without full context and knowledge of the issues being faced by the questioner. And I think there's an opportunity now for ongoing dialogue. I think something like a listserv is an excellent idea. I'd like to run with that personally, but obviously I have to see what others here think of it. That would be one place we could delve more deeply into questions like this. I will say also that, in terms of receiving technical assistance with evaluation, logic modeling, ROI, if you are participating in the NIFI grant, the National Public Health Improvement Initiative, and you are a PIM, such as Josh, you can request TA through your project officer at OSTILTS if you are knowledgeable of that person at the state or local level and receive assistance in this area. So I'd like to see this as a way to keep this dialogue going. Certainly as we develop the tool, probably be holding another webinar to really walk people through it and provide ongoing assistance in this area.
And pardon me, we do have another question. It's coming from the line of Darlene Eddy. Please proceed.
Hi, I'm from Clinton County at Plattsburgh, New York, and we underwent a lot of changes to our strategic plan with resource optimization, and I wish I would have seen this presentation before that for return on investment. We've used it a little bit previously, but I really like the way this is laid out to show the short-term benefits. The long-term, though, is much harder. We, every year at budget, fight for our public health dollars, and we're saying, if you let us have this, it'll save you here, and that future savings is much harder for the stakeholders to buy into. But this short-term ROI, I think, can help just with the little steps to show that we are efficiently using our dollars and why we need to retain the dollars that we have. But a lot of times staff, when they see changes like this, they fear that there's downsizing, and we have had some downsizing. So it's difficult when you put the changes in. How do you deal with staff when it comes to wanting to make these changes, wanting to make things more efficient and more effective, yet there's the fear that, okay, you've went through 20 different hands and now it's down to 3 people. Am I going to lose my job? So there's distance sometimes. How do you get past that?
Sure. So it's very important to make clear the process, both the process and the goal of the ROI being undertaken. If that is unknown, then I guess you can communicate that. If it's talking about reinvestment, if it's talking about documenting what we're doing so that we can defend our budget, if it's talking about investing our limited staff resources wisely, do that. But it's very important to conduct this in an inclusive and transparent process as possible and communicate the goals and objectives right up front to both internally and externally, and keep that going throughout the process. That way you can best assure that those you need to rely on to supply the needed data, as well as carry out the basic QI reform, are bought into the process, as well as on the other end, the ultimate, when you run with this in the public sphere, will it be interpreted and used correctly by policymakers and decision makers? So that it just rests in being clear and specific right up front throughout the process about the intended purpose and methods for going about this.
Okay, how inclusive is the group? Because here we had a lot of changes that went on, and there was a lot of concern that it was more just the managers. There's 8 managers, and there's 90 staff, and there was more managerial direction, and there wasn't questions asked enough of staff. And at times we feel like sometimes when you bring too many in, then there's too much, and there's too many going off on a tangent, and then we lose focus, and it's hard to bring it back. We struggle with how inclusive, or at what point do you give out information and get that buy-in, because a lot of times people feel like it's secondhand. They're getting it after it's already said and done. There's no no way to make any difference or change in what was to be.
Right. Obviously, it's a balance, and obviously, if the ultimate authority over decision-making does not rest with your advisory group or work group, then there should be no pretense that it does. It's a balance of pulling folks together early and periodically, but using their time efficiently. So there's no, magic way to do this. It's just a balancing act. I do know that I've heard Josh speak about how they approach this through a whiteboard. Some of the, in fact, examples he walked through, they approached this through a collaborative whiteboard process, and then kind of went very efficiently on zeroing in on the issues. I don't know, Josh, if that would be helpful to talk about the scope of involvement and who is involved and at what point and how.
Well, and this is Denise, and I'm sorry to interrupt, but we are out of time. And so what I would like to suggest is that, well, first of all, I'll be putting my contact information is currently up on the screen. If you have follow-up questions for any of the presenters, if you're looking for TA around ROI, please just feel free to shoot me an email. I will also send out my email in the follow-up email at the conclusion of this webinar. So I'm sorry to interrupt. This is a great discussion, but we do need to be respectful of everyone's time. Once again, want to thank our presenters as well as our funders and, of course, our participants for the robust discussion and these terrific questions. Once again, if you're in need of further information about return on investment or other topics related to accreditation and QI, you can contact me at the email address listed on the slide. And once again, we value your feedback, so please take a few moments to provide us with your feedback on today's webinar. Thank you all, and that concludes today's session. Have a great day.